Hey everyone, what's up? This is Dr. Charlie Johnson, physical therapist, and this video is going to be perfect for you if you have some type of back, butt, or sciatica pain, leg pain, numbness, and tingling. Maybe you have trouble driving or sitting or even sleeping, and you've been told you have Piriformis Syndrome, maybe a bulge, herniated, or extruded disc as the cause of your pain, and you want to figure out what's going on so that you can fix it. Well, in this video, I'm going to break down two cases of people with sciatica, very similar on the surface, similar location, similar kind of descriptor of what's going on, but two very different causes. This matters because the treatment might slightly differ. And so we talk about these cases, we break them down completely step by step so you can see exactly how we help people all around the world solve these problems. And so watch, learn, and listen, and ask yourself, how can I take these concepts and apply them to my own unique situation? As we work through these very different cases, we've got G and we've got M. You can see there the pain body diagram where they hurt is very similar, but again, two very different cases. So we're going to review their case, what they submitted to me prior to their interest in working together, and the results of their self-movement exam that I have everyone go through. We're going to synthesize the results of that movement exam, what it means and the things that aggravate the problem. We're going to crack the case and identify exactly what's going on, and I will show you specifically how you can do that. If at any point you're interested in determining the most likely source of your symptoms, be sure to download my Better Than an MRI diagnostic guide above for free, because as you can see, there is plenty of information there to determine the most likely source of your symptoms without needing MRIs, further tests, things like that. All right, so step one, let's review the case. This is location of symptoms. And ask yourself as you go throughout this, do you resonate with this case? And does this sound like something maybe you're dealing with? And start to pull out the nuggets and apply them to your case as I highlight some of the inconsistencies which allow us to figure out what's going on and the difference between the two. All right, so this is where G hurts. And again, this is the case review. I ask everybody before they work with me to submit a detailed case review, and this is it right here. So G is a male in his 30s. He's got right leg symptoms. We're going to go through this, and then I'm going to summarize everything. He believes from the hip and glute all the way down, different parts of the leg hurt on different days, hip, glute, hamstring, calf, foot, numbness, tingling, shaking of the leg, not a whole lot of pain, only notices it really when driving and pushing on the brake. So much muscle weakness and shaking of my leg, I'm terrified to drive and getting around. I cannot hold the brake pedal for long periods. That's how bad the muscle weakness and shaking and numbness is, but it's not every day. I have some good days and bad days. He's had it for 9 months. I asked this question, what originally caused it? Doesn't really have an idea. Maybe pushing on the brake. He also runs and plays squash. What diagnostic tests have been performed? Book for an x-ray, MRI next week. Looks like tried maybe some massage, chiro, physio. One said with muscle weakness, do strength training. Did that for 5 months, nothing. One said piriformis, flossing, done that for 5 months, nothing. One said it stems from the neck. So you can see here in the next question, nobody really knows what's going on. They can't agree. He does have some good and bad days, which tells us, by the way, he can heal. If you have good and bad days, it tells you you're going to have good days. Yes, you're going to have bad days, but the fact that you have good days, if you're willing to work with someone and do the detective work needed to solve the problem, you can multiply those good days. Pain is not delayed, comes on immediately in the moment. His symptoms do seem to move or shift around. All this will become important as we chat through things later. Stress does seem to increase his pain. If he's distracted, it doesn't change the pain of the symptoms. I ask for any significant life events, good, bad, or indifferent around the time symptoms started. And he said, well, not sure, but it was around the time my grandma passed away. Driving is really the thing that makes his symptoms worse. What helps? Running, deep glute stretch. Which of the total body scan self-assessment motions make his symptoms worse? None of the motions make his pain or symptoms worse. Here are the motions that I have people go through. So this is the self-movement exam, the total body scan. I have people go through basically 6 motions, pretty much done on the right and left side of the bodies. The twist, knee to chest, figure 4, leg raise, forward bend, backward, back bend, and then people can obviously add their own motion into there. And this gives a lot of information as far as what's going on. And again, we'll talk about how that helps us. He can walk on his heels, some weakness walking on the balls of his feet, no loss of bowel or bladder control, no history of cancer. He has tried strength training, nerve glossing, meaning flossing, I think. Acupuncture, nothing has helped. That was a typo. Major impact on life, can't drive car, can't get around. Driving is obviously the problem, and nothing else he wants to add. All right, so let's go off of this, and then obviously we will compare and contrast that so you can see how we're able to differentiate the cause here. So again, we go through the self-movement exam. No motions are yucky. So if we synthesize all the information we have from the case review, Well, this right here, what you're seeing right now, is a snapshot of what I call a private healing log. We work with people all around the world dealing with back, butt, or sciatica problems. And this is something we have folks record to get a baseline, their top 3 yuck emotions, their top 3 pain triggers. And the reason that this is really important that they go through this self-assessment is because you can't manage what you don't measure. So we have people go through different motions and objectify it. If it's yummy and it doesn't hurt, great. If it's yucky, then is it low yucky, medium yucky, or high yucky? And we supply and or kind of connect some scores to these different activities or motion. Then we can monitor this week to week to determine if what we're doing is working or not working. But anyway, this baseline is really telling. I'm going to come back to this because there's a huge inconsistency here that is very telling and diagnostic. Now, you don't know it yet, but I'll come back to it in a moment. So again, no yucky emotions. Driving is super yucky. And that's that. Okay, so now let's synthesize everything. Let's boil it down and let's crack the case. Now, when it comes to cracking the case diagnostically, we've got the problem, which is the main focus here, the diagnostics of things, what's causing his symptoms, and then the solution. Let's talk about the problem first. So the first step whenever I review a case or whenever I work with folks is to really rule out anything that's big, ugly, scary. Clear the bus, big, ugly, scary, so to speak. All right. And the big things that we're looking for and the reason behind some of those pinpointed questions on that case review, which I just briefly went over, is to rule out things like cancer, tumors, fractures, infections, things like that. Now, a lot of people come to this and say, Dr. Charlie, I'm just going to get an MRI to make sure that I don't have cancer, I don't have a tumor, something like that. But realize that we're not screening people blindly. We have evidence and test clusters, if you will. Things that we take from the history, things that we take from your demographics, things that we take from your movement exam, etc., to identify, hey, what is, the probability that you have something like that? And does, upon review of your case, does that warrant that we send you out and or refer you out to get imaging? For example, a test item cluster that we know that is highly sensitive for and or a great way to screen for cancer is if someone is greater than 50, they have a previous history of cancer. That is the biggest predictor of future cancer, or cancer is the cause of back issue. Unexplained weight loss, again, losing weight and you're not really sure why. And failure to respond to natural treatment, but not so fast, because if you're watching this video, both of these people have tried many different things and it didn't work, but they didn't take a scientific, systematic approach. And as you'll see here in a moment, all the people that G worked with were barking up the wrong tree, treating one thing when they should have been treating another. So you got to be careful because conservative treatment, well, what does that mean? Was it good? Was it bad? What was it, right? So again, this isn't just, hey, you're greater than 50, you need to rule out cancer. G is in his 30s, doesn't have that, no previous history, no unexplained weight loss. Yes, he's failed other treatments, but that doesn't immediately warrant a referral out, right? So again, a very good screening sort of cluster here that if you have all 4 of these findings, or even if you just have a previous history of cancer, probably means you might want to get that checked out first. Okay, so and we would have referred out and or sent him for some x-rays or lab work if he fits some of those findings, but he doesn't. We also have research which supports the ability to screen conservatively for fractures. Generally female more than male, age greater than 70, significant trauma, prolonged corticosteroid use, and again, none of these. All right, so move on. Female athlete triad could happen in males too, so we'll move past that here in a second, but irregular menstrual cycle, reduced bone mineral density, eating disorders. When you hop on one leg, you get sharp pain in the groin, things like that. That's not even where he's feeling symptoms. So that's gone. And then peripheral arterial disease, very young male, no major significant cardiovascular history. And as you'll see here in a moment, it is very much of either the mind or the body, and we'll help figure that out. All right, so no real clear signs of vascular arterial disease here. So we'll minimize that and boom, that is gone. Step 1, should they even be somebody who works with us? In this case, they're potentially in the right place. Now we need to move on. There's nothing big, ugly, and scary. Okay, now the second thing we do is that we need to ID the source. Mind versus body. Now, this is going to be really telling for anybody who's watching this, and I hope you stick around for the rest of the video to really see the contrast between these two things. So contrary to popular belief, right, and how we're biologically wired to believe that all pain is physical, especially with the use of x-rays, MRIs, things like that, I want you to understand as you're watching this that the mind can absolutely cause very real physical sensations anywhere in the body. It doesn't mean they're made up. It just means your mind's probably making a bit of mistake and actually very intelligent, right? And functioning at a very high level. So if the pain is caused by your mind and the pain is due to danger, it is not due to damage as if it were a problem within the body. So what I'm going to share with you here, again, is a snippet of what we help folks figure out. So once people work with us, we supply them what we call an evidence list. And the purpose of this is to help people separate the signal from the noise and be very objective about what's going on. So innocent until proven guilty. Most people think, oh, I have pain right here in my butt. It's going down my leg. And because of that, you know what, Charlie? It's sciatica. It feels shocky. It feels weak. It feels all these things. Just because something feels a certain way doesn't really mean anything. By the way, the brain allows you to feel everything. And so we have people complete an evidence list. And I ask people 13 different questions to help them narrow in on the most likely source of their symptoms, mind or brain versus body, and what might be driving it. And so you can see here, I just took all these answers from that case review, and this is the evidence list. And what's going to happen at the end is it's going to give a readout, as you'll see in a moment, of the most likely source of what's happening, brain or body. So, are you unsure as to why your pain began? No clear injury or cause? Yes. Physical problems generally are brought on by physical traumas or insults, injuries. In this case, there's no clear injury. He doesn't know why it started. Is your pain chronic? Yes, 9 months. Most things in the body heal within 3 to 6 months. Did your pain begin during a time of fight or flight? Yes, around when his grandmother passed away. We'll mark yes. Is your pain inconsistent? Do you have good days and bad days? Yes, I have some good days where I barely feel it, and I have some really bad days. Well, problems that are structural of the body are generally very consistent in their response. A disc isn't there on Monday and not there on Tuesday. Does stress trigger your pain? Yes. And that should say stress does seem to change the level of my pain. So I goofed that up. But yes, he said it does. Do you experience relief of your pain with distraction? He said no. Do you have pain or symptoms or problems in other parts of the body? Many people with symptoms that are due to a centrally sensitized brain or nervous system have symptoms all over the place, right? And they also have symptoms that shift around. He mentioned his symptoms do shift around. Delayed onset of pain? Nope, he feels it immediately in the moment. A lot of times people with symptoms of the mind, their symptoms will not arrive until much later or after they're doing something. So they can run around, they can do stuff, they can move, and then they'll say, I did great at PT, but then later that night, the next day, I couldn't move. That screams a more centrally sensitized issue, an issue of the mind. Have you been given many or no clear diagnoses? Yes. They're unable to pinpoint it. Again, tried all this different stuff, didn't work. Are you a high pressure perfectionist, people pleaser, type A, good student type of personalities, predisposes the mind to being a little bit sensitive, a little bit more in an elevated or fight or flight state? I don't know him enough to say, so I'm just going to say no, and I'll give him the benefit of the doubt. Is it hard to identify yuck emotions that clearly and consistently reproduce your pain? If the problem is of the body, he should be doing those motions and they should clearly hurt. We'll talk about this in a moment, and I'll go back to it in a second. He said, yes, I'm having trouble doing it. None of these motions make my pain or symptoms worse. Has there been a lack of response to physical treatment? Question 13, yes, I've tried strength training, flossing, acupuncture, nothing has helped. And look here, 69% probability, diagnostics occur in probabilities. The symptoms are more centrally driven by the mind or by the brain versus the body. So we're not going to talk about herniated discs with him. We're not going to talk about spinal stenosis, Piriformis Syndrome, all this stuff, by the way, he's going to be told he has, and you saw in the case review, he was already told those things, because that is going to lead him down the wrong path. He can do all the strength training, all the acupuncture, all the flossing he wants. It'll work temporarily because it'll scramble the pain signals centrally, but it won't actually solve his issue physically because it's not a physical problem. It's showing up physically. His physical symptoms are a consequence of psychological dis-ease. All right, so that's that. Now, look here. None of these motions make my pain or symptoms worse. 69% mind, he's tried this stuff and it hasn't worked. This is very telling, and this is part of the reason why I have people go through motions to help us gather further clues as to what could be the cause. So the probability has symptoms of his brain even goes higher because look at this. He's telling us, here's what he's telling us. I don't have any yuck emotions, but I just can't drive. Here's why this doesn't make sense. And if you're somebody who goes through certain motions and doesn't really have any pain or problems, or you go to the doctor's office and they're moving your legs around and you feel good while they're doing it, but then later it comes on, or maybe one day this leg raise hurts and the next day this movement doesn't hurt, and things just seem really inconsistent, but you just can't sit, you just can't drive, you just can't do these activities, then that's really weird. And let me explain why, right? So let's look at this motion right here. If I blow this up, this is how we love to have people think of things because I think it just makes sense. If you can't do this yucky leg raise If your symptoms are of the body, then realize that this leg raise shows up for you. We call this morphing motions in many different ways. So it shows up potentially in the way you sleep, in which case you won't be able to sleep if this is how you sleep. If you're doing yoga and you have a yucky leg raise and you're doing this motion, it's not going to work. If you're getting nerve flossing, well, they're putting you into this yucky leg raise motion over and over again. Right? But look here. There's many other ways it shows up, but look here. Driving. And so driving is a leg raise, but he doesn't have a yucky leg raise. So what does that tell you? It tells you that there's some learned or conditioned response, we call it, some learned association between driving and pain. And that the belief that driving is the problem is the reason that driving is the problem. It's not because mechanically he can't do what he needs to do for driving. Driving is a leg raise. You also see knee to chest here. Knee to chest might also show up when you're driving, right? Very similar motion, but he doesn't have any of these issues and he can do all of these motions pain-free. And so that tells us structurally he can stress the sciatic nerve, he can pull on it, he can pull on the piriformis, he can move his discs, move his joints, move the entire mechanical system of the body, but he just can't sit. And so it's not a mechanical problem, or it's very highly unlikely to be so. And then when we take that and we combine it with the rest of his evidence, he's even higher than 69% mind. He might be 75%. Hopefully that makes sense. So this is, G's case is highly inconsistent with the problem of the physical body. His pain is not due to damage. His pain is due to an experience of danger. Pain is an unpleasant sensory experience designed to protect you from some actual or perceived threat or danger. In this case, he's going to go and get an x-ray or an MRI, and they're going to show all kinds of stuff wrong with him, because who in their 30s doesn't have something wrong with their spine? And they will treat it. They may go do injections. They may go, do some surgery to his spine if they find the problem. But it will not work because, again, they're barking up the wrong tree, treating the wrong thing. Now, really briefly, before I compare and contrast to the other case, the solution for this type of issue, well, we've created a 4-step pain relief process. First step, optimize things mentally and physically. Mentally, beliefs, fears, worries, concerns. Physically, habits, routines, things like that that might be contributing to their problem. We've got to self-assess. We showed you a picture of some of the things that we track. Then we've got to systematically use movement to restore safety to his sensitive nervous system. And then we've got to teach him how to get back to life and tolerate driving more and more. But what's interesting is rather than trying to fix his disc or fix his piriformis or something like that, or whatever else shows up on the image or the MRI, the goal really becomes just to change his reaction to pain and his belief system surrounding driving, not to change the pain itself, because the pain or the symptoms, the numbness, the weakness, the tingling, call it whatever you want, all sensations are a consequence of psychological, again, dis-ease. And so if we can reduce that dis-ease by changing his reaction to his symptoms, then the pain fades. So just a quick picture here. He's in a state of danger and we need to restore safety. How do we do that? We can do it many ways. For him, the focus is going to be on retraining his brain by using safe motions to help him break this negative feedback loop. This is pain right here. So if you're getting treated right now and you're only looking at this as a body problem, you may be sadly mistaken. What happens is sometimes when people do things, it hurts. So maybe this person, hey, driving hurts. And then what happens? Well, tells the brain, oh my gosh, what's wrong with me? Why is driving a problem? They go to Google, they go to YouTube, they become more freaked out, more fear, less movement, less driving, let me avoid it, more fear. You reinforce that what you're avoiding is bad and dangerous, less driving, more hurt, and your life becomes smaller and smaller. And so when we can educate him and have him know and understand and have conviction in the belief that, oh my gosh, hurt doesn't necessarily equal harm. And even though I feel the sciatica in my leg, it's not that it's not real. It's just that my brain's making a bit of a mistake. Wow, that's crazy. I can move more. I can sit more. I'm not broken. Less fear, more safety. I'm sore, but I'm safe. And before you know it, there's a positive feedback loop. Education is going to be a massive part of this individual's solution so that he knows, K-N-O-W-S, knows pain. And part of that is by helping him break his belief system, by showing him the evidence, and by sticking to the clues, being very objective about what's happening versus all the emotion of what he's going through at the moment. All right, so that's the value of this evidence list. If you're a logical person, you would look at this and say, I can't really argue with that. And you could try, but you'd be fooling yourself. That's G's case. Of the brain, not of the body, but he's got pain in the body. It's right here. That's sciatica, Charlie. No, it's not. You could describe it as sciatica symptoms or in the distribution of that, but it's not. Now let's compare that to M's case. Same exact location of symptoms, just on the left side, not the right side. Oh, by the way, before I go there, remember here, what makes you better? Running helps a lot. Here's another indicator. Running is a leg raise. And so we know with 95% certainty that if you do not have a positive straight leg raise, if you go and you do that test and it does not recreate your symptoms, that you do not have sciatica. It's a very good screening test to rule out sciatica. Again, he says, I can run and it's a leg raise. But then on the other hand, he says, I can't drive and oh, that's a leg raise too. Do you see the inconsistency? Do you see the inconsistency? When things get weird, they're generally wired. And this is a weird case and it is wired. All right, so now let's go to M's case. M, male in their 40s, pain in the butt, back of left leg and calf, tingling in foot and toes. Very similar, different side. Pain came on slowly about 3 weeks ago. So we're already seeing the difference. Instead of 9 months, 3 weeks ago. It peaked and has not subsided for the past 2 weeks. Somewhat manageable during the day, gets much, much worse at night, prevents him from sleeping. Pain at night while sleeping, while not always a sign of inflammation, is often a sign of inflammation. What originally caused your pain? Lower back injury while playing ice hockey about 10 weeks ago. There was no collision or fall. I believe I must have simply moved or twisted awkwardly. This injury did not have any sciatica associated with it. The pain was isolated in the lumbar region of my back. I did 2 weeks of PT, seemed like it solved it. Now, several weeks later, the sciatica started out of the blue. I assume it's related to the original back injury. Doctor states, hey, you've got sciatica. He thinks it may go away with PT. What do they believe to be the source? Sciatica. Is it consistent? It is consistent. Consistently bad at night, a little bit better during the day. No, my pain occurs immediately in the moment. Symptoms are not delayed. Doesn't move or shift around. He said, I've tried some McKenzie movements. He's trying to get his pain to centralize or move from further in his leg up to his butt. Doesn't really matter. And he says, sometimes I think I just imagine it moving around. Right? So maybe, maybe not. Does stress influence it? No. If he's distracted, yes, he may notice it a little bit less. Significant life event? Nothing really other than what he already told us, playing ice hockey 10 weeks ago. A lot of yuckies, driving, sitting, putting on shoes, sleeping, lying on his back or laying on his side. Many people reach out to us with very similar cases where they're laying on their belly because that's all they can do. All right, so we help people with symptoms of both the brain and, in this case, the body. What makes it better? Standing, walking, lying on stomach with pillow under my chest. So he went through the total body scan and he found a figure 4 right, leg raise right, and forward bend were all yucky. So I'm just going to move these out. So it was forward bend, leg raise. I'm just going to shift them out here. These were the yuckies. Okay, now we go back. Yes, he can walk on his heels. Yes, he can walk on his toes. Doesn't have loss of bowel or bladder. No previous history of cancer. What else have you tried? McKenzie stuff. Fearful of making his problem worse. Tried prednisone, muscle relaxers. Nothing really. Serious impact. Hasn't been able to work, drive, sleep, or participate in normal activities for 2 weeks. He said, I need someone to confidently tell me what exercises to do. I feel nervous simply watching YouTube videos and trying exercises because I may make my problem worse. Smart guy. He's an engineer, recognizes his limitations, and feels he has a solid grasp of how to solve problems, but just not really sure what to do here. So that's that. He's ready to solve it and wants a sciatica plan to resolve his sciatica problem. But is it really sciatica? So again, he went through the self-movement exam. So he did his twist, his knees to chest, figure 4, leg raise, forward bend. These were the yuckies. These 3 yuckies right here. Now, what's cool is we talked about how, remember how leg raise is driving? Well, if there is a yucky leg raise, then we can predict that driving will be one of his triggers. Even if he didn't tell us, if the problem is of the body and we know he has a yucky leg raise, then any place or in any way that this leg raise shows up, he will have trouble or should have trouble doing it. That is called consistency between the movement and the pain or problem or trigger relationship. Okay. Now, figure 4. Well, he's going to have trouble putting on his shoes, putting on his socks, bending over to do things. Any type of stretch that he does to his piriformis, or if he's sitting in a certain way, it's going to make him worse because this is how a figure 4 shows up. And what do you know? Consistency. On this side, there's no consistency. I can do all these things which make up driving Charlie independently and they're fine. They're all yummy, but I just can't drive. That's weird. We talked about why. Oh, I can't do a leg raise. I can't do a forward bend. I can't do a figure 4. Ding, ding, ding. Well, guess what? Of course you can't drive. Of course you can't sit. Of course you can't get your leg in a figure 4 to put on your shoes, put on your socks. Do you see the consistency here in the movements and the pain relationship, how it just adds up and it matches, and now here it doesn't. It's very telling. Of course, he went through the rest of the motions, and we just asked the people pull their top 3 yucky motions. And again, you can't manage what you don't measure. So we need to start measuring this so that we know what's working. We're not just thinking, we want to know. So now we synthesize everything. We crack the case. Again, we've got a solution and we've got a problem. Rule out big, ugly, scary. We talk about cancers, fractures, vascular stuff, other funky things. He doesn't have any red flags, no history of cancer. His age is younger than 50. Yes, he's failed and tried some conservative stuff, but again, probably wasn't what he should have been doing anyway. And he has no unexplained weight loss, no signs of fracture or anything else in his history. So we're going to move past that. We've ruled that out. Doesn't need X-ray, MRI, anything. Now we can ID the source of the mind versus the body. Again, I've taken the responses from his case review and put it into this evidence list, and you can see already it is 85% probability that symptoms are of the body. We're not looking for 100%. We go based off probabilities, and we don't just look at one of these things. And so putting all the puzzle pieces together and looking at all the information to determine the most likely source of what's driving his symptoms, he has a clear injury and consistent with a structural problem. It makes sense timeline-wise. His pain is not chronic. It did not begin around a time of fight or flight. It is consistently bad at night. Stress does not seem to change his symptoms. He did say that distraction does seem to improve it, so I should be a yes there. Either way, still large majority of things point to body. Do you have symptoms or problems in other parts of the body? He didn't mention any. Does his symptoms shift around? He said maybe. Maybe that could have been a no, but maybe. Do you experience delayed onset of pain? No, in the moment. If you have a structural problem, as soon as you hurt yourself, you feel it now and you'll feel it later. You don't just experience delayed symptoms. Doctor says he's dealing with sciatica. They tend to agree. I don't know him well enough to answer this, so I gave him the benefit of the doubt again there. Is it hard to identify clear and consistent yucky emotions? We just spent some time talking about that. No, it's very clear cut, and it makes sense with regards to his triggers and the things we can't do. And we know now, as part of the solution, if we fix the figure 4, the leg raise right, and the 4 bend, then we will restore his ability to live life, because all those things show up in life. Has there been a lack of response to physical treatment? I'm going to say yes, he tried some stuff, but really out of fear, he hasn't done much else. So again, majority of his scores, even though I goofed some things up in there, do point to it being originating from the physical body, in which case pain equals damage. So now we say, okay, Charlie, on this side, you identified symptoms as being of the mind, where pain was due to a danger response, a fight or flight response, dis-ease within the nervous system, but you didn't go any further than that. We don't need to, all right? But let's just say that if symptoms are of the body, then we could go further if we want. This is where, if you'd like to download my Better Than an MRI DIY diagnostic guide and avoid MRIs and other things, then you can likely figure out the most likely source of what's going on, okay? So we can dive into this, and let's follow based off his case review. Do you have back, buttock, hip, and or leg pain? M would say, yes, I do. And you go up here. So yes, I have lower back pain, pain along the belt line with or without leg pain, numbness, or tingling. Well, he did have lower back pain, but what did he say? Let's go back to that. What he said is, the pain was isolated in the lumbar region of my back. 2 weeks of PT resolved it. Now, several weeks later, the sciatica started out of the blue. So he no longer has back pain. He only has sciatica. So if we zoom back into that, it's like, yes, I have lower back pain. Well, that's not really true. He does have the leg pain, numbness, tingling. So where do we go? What we do is we go down here and we say, I don't have back pain, but I do have buttock and or leg pain. And we check out what the DIY guide tells us to do, and we follow along. I have no back pain currently, but I may have had back pain in the recent past. But I do have leg pain, numbness, and tingling. So again, it looks pretty much just like what he's dealing with. If we were to match it up, actually, we should have taken that away, by the way. We should have taken that little back area away. But you can see those sort of match up, and here we are. And try this out. If you have this, chances are, if you pull on that nerve by doing the leg raise, remember, that was one of his yucky motions. He already told us that he has a positive leg raise, and that's a really good screening test. Yikes, that hurts and causes his leg pain. If it didn't hurt, he could go somewhere else. Sciatica is the most likely source of symptoms. Now, he only had it on the one side. He did not have a positive straight leg raise on the other side. Let's just say he did have yucky leg raises on both sides, and this is what we call a positive cross straight leg raise, which increases the probability even more that he's got a disc problem. But he only had the one side, and it's like, well, what could be causing it? Well, maybe Piriformis Syndrome, or most likely in his case, a disc extrusion or large protrusion. All right, and here are some of the signs. So shifted, little to no back pain, primarily leg pain. As far as where his symptoms are going down the back of the leg, you can see here. Probably either an S1 problem or an L5 problem. L4 can cause some symptoms down the back of the leg, but based off what he's telling us and what we know probability-wise, these are the most two commonly affected nerves in the spine, and it's probably due to a disc issue. Now, the reason it's difficult to say is an extrusion, large protrusion, something we call a sequestration. You can see here, protrusion, the disc material is still intact. Extrusion, the disc material has left the stadium, left the donut, so to speak. Either way, a lot of people with large protrusions or extrusions actually feel better with sitting, better lying down and reclining. They feel worse with standing and walking. Now, he's not fully mentioning that, but he does say, I have almost no back pain. It's just leg pain that came on, very common with those issues. Here's a more classic presentation of a herniated disc. Central back pain, again, his back pain went away. Pain first thing in the morning is the worst. His is worse at night, so you'll see that around like a 2, 3, 4, 5 a.m. as the disc sort of plumps up throughout the night and rehydrates. Trouble straightening or standing up, even though he's standing and he can stand. You can tell he's a little bit crooked and having trouble being completely upright. I don't know about this. I'd have to ask him, but I do know that bending is really hard, sitting and driving as well. He does feel a little bit better standing or lying down. He mentioned that. Not sure about the coughing or sneezing, and not sure about his history at the moment. I can't recall. He was a little bit shifted. And so you can see a lot of things. We don't just look at one thing. We don't say, oh, well, he doesn't have back pain, but you know what? His pain's actually better when he's standing and walking, but he's got every other sign consistent with a disc. So, you know, because he doesn't have that one thing, that means that we're confused and we don't know the cause. We do know the cause, okay? And we don't need an MRI to get us any closer. Chances are he's got a large disc protrusion or disc extrusion. At the very least, we can say herniated disc almost without a doubt. And we got that by going through this DIY diagnostic guide. All right, so hopefully this has been helpful. As it relates to solution, it's a little bit different. We still go through the exact same 4-step pain relief process. We have to optimize things. We have to help this person figure out, well, hey, you've got these yucky motions. How can we optimize your healing environment? Well, how could I do that, Charlie? Well, you mentioned that you have a yucky leg raise. So how are those things possibly showing up for you? And what do we need to temporarily tweak or modify? And what detective work do we need to do so you're not constantly picking the scab when you're doing all these different activities? It doesn't mean avoid life. It just means start doing some deep detective work to figure out habits, routines, things you don't know that are keeping you from getting better. And then obviously beliefs, fears, worries, and concerns. A big one for this gentleman is that we know that the worse the disc herniation, for example, an extrusion versus a protrusion, the better the chances of natural resolution. And that might be a stat and or some information that might help him actually reduce some fear, worry, or concern and ultimately help him heal. We teach him how to self-assess. Again, you can't manage what you don't measure. So we have to know if what we're doing is working or not working. Otherwise, you're just guessing. So week to week, we would check in with that. Next step, mind and movement is medicine. The goal is never to take more medicine than needed. It's to take as little as necessary. And if you think of movement as medicine, then why would you do a sheet of things? Why not work through a process, a very scientific process, to identify the one motion you need to do to resolve your issue? And you should see it work immediately in the moment so you can tell if it's something makes you better, something it's a waste of time, or something is going to make you worse. And it should be safe. It shouldn't make you worse. And finally, back to life. Not only short-term pain relief for this person so they can improve their sleep. By the way, it's the first thing we're going to chat about with this person, because if you're not sleeping well, you're not healing well. So we would teach him exactly what to do as it relates to his nighttime routine, sleeping surface, positions, all those different things as it relates to optimizing his sleep mentally and physically so that he can aid in his recovery moving forward. And then long term, we want to get him back to full speed, and we want to give him everything he can to have the best chance of not having this reoccur in the future. So again, if pain is due to damage, problem within the body, then we need to help him become his own best anti-inflammatory. There's some damage. We want to move him to a place of from danger, from damage to health, to safety. And instead of maybe doing as much of the brain work, we're going to teach him ways to move his body that are safe, ways to move his body that immediately improve his movement experience. Wow, I had a yucky leg raise, but when I did that thing, my leg raise immediately improved. Wow, I'm okay. This might be something that could help me out. Awesome. Now that I can move a little better, I'll move more, less fearful, I'm more safe. And so you can see, regardless of if it's an issue of the body or of the brain, the approach is really darn similar. So we aim to teach people principles and concepts and a universal pain relief process so that they can learn how to heal themselves naturally. All right, so there you have it. Thank you so much to G and M for sharing their case. Two very similar cases on the surface, but two very different causes, and therefore two different treatment paths. Same process, but choose your own adventure, and they're going to go two different ways. And the only way they would know that is if they had somebody dissect and decode their case to determine the root cause of their symptoms. If you're interested in potentially having me review your case to do just what I did here for G and for M to determine the most likely source of what's going on and really start to lay out a plan, and you're interested in potentially working together, go ahead, click the apply link down in the description somewhere, set up a time to chat with us, and then follow instructions to submit a formal case review. Thanks so much. Let me know in the comments, was this helpful? Was this not? And what did you learn? Thanks, everyone.